Thank you so much for having me. I hope you can hear me. I was tasked, I must confess, at relatively short notice for giving a lecture on understanding the effect of heavy menstrual bleeding on iron stores. It is with great pleasure that I speak to you tonight and give you some insights into this problem. I have several disclosures. I've received travel and research grants from numerous companies. I've done drug research trials, and I've sat on many advisory boards. But most importantly, I have to disclose that I cannot spell. I am a dyslexic, and my spelling is atrocious. So you are tasked with trying to read my slides and to decide if I've got any spelling mistakes, so that might keep you busy. So let's start with a case. We're going to start with Mrs. HMB. She comes to see you about her menopause symptoms. And in passing, she tells you that she thinks her 16-year-old daughter is having heavy periods. And do I think that she needs to see somebody? So this is what you have to think about and think is your answer. No, because it's normal at her age to have heavy periods. No, she must take 2 Panadols or Panados if she has pain and it will settle. Or yes, she must see somebody as it can have consequences on her well-being. So I want you to think about this answer as we go through. First of all, we must remember that from menstruation to menarche, or from menarche to menopause, menstruation on average lasts about 5 to 6 days. And that brings us to the average time spent bleeding in a woman's life is around about 5 to 7 years. That's quite incredible, actually, if you think about it. And we are still amazing as women. On average, our blood volume lost over our lifespan is approximately 14 liters. Who would have thought? So what is normal menstrual bleeding? So normal menstrual bleeding is the blood loss for 7 days of a cycle, and the average cycle should be between 21 and 35 days. And on average, most women lose between 35 and 40 mils of blood. But heavy menstrual bleeding is defined as lasting longer than 7 days, with a monthly blood loss of more than 80 mils. Obviously, that's quite easy to measure these days if you're using a moon cup. A moon cup is a very popular thing amongst young girls. It's a menstrual cup, and obviously that saves in sanitary wear, and you would be able to measure it. But we'll go through a measuring scale because it's extremely difficult to judge how much you're bleeding. So in fact, the prevalence of heavy menstrual bleeding is likely to be higher than reported. And in this very elegant study that was done in the Royal College of OBGs in the UK, they estimate that about 25% of women in their reproductive age actually menstruate more than 80 mils per cycle. But there is considerable variation in the prevalence rate and in reporting. And these disparities, and you can appreciate these disparities, they're usually due to, perceptions. Your perception of heavy menstrual bleeding might be totally different to my perception, and for instance, if a woman is bleeding with clots, she more than likely is having heavy menstrual bleeding. So heavy menstrual bleeding is underdiagnosed and often poorly treated. And when they surveyed over 1,000 women, they found that 50% of these women had never visited a doctor for their heavy periods. And of these women, 49% believed that it was just part of being a woman. And 62% of women were actually unaware that they actually had heavy bleeding. And only 23% of women had visited their doctor and reported that they were not informed about treatment options. So many women themselves think that it's normal, and many practitioners don't ask about it. So what do we know about our own South African data? We have very little data. But in 2 studies that I found, we found that the prevalence of menstrual disorders impacted amongst women in our local area, in the Venda-speaking teenagers, in the rural areas, that 47, nearly 48% of girls do not study or do homework during their menstrual cycle. And more than 23 or 25% of girls did not attend school during their periods. And we certainly know about period poverty. And period poverty is a real problem in Africa, and that menstrual health management and schooling experience amongst female learners in Gauteng, for instance, 22% of girls between the ages of 16 and 18 were unlikely to go to school during their periods because of insufficient sanitary wear. And this is even bigger in women or young girls who had heavy menstrual bleeding. In fact, our own university, the University of Witwatersrand, came up with a fantastic recyclable sanitary pad that lasted for a year. So this is a super absorbent sanitary pad that you are able to wash and reuse. So all of these things need to come into being. So it's not just the insufficient sanitary wear, but it's also heavy menstrual bleeding that I will show you impacts on schoolwork. So here was a study where they looked at anemia and iron deficiency anemia amongst women in two areas, KZN, one in the Western Cape, and there was actually a study in Gauteng. And if you look particularly amongst our HIV positive patients, those women in reproductive age groups were much likely to have anemia and iron deficiency anemia if they are HIV positive. But nevertheless, if you have a look at this forest plot, you'll see everything is to the one side, saying that we really do have a problem with iron deficiency anemia amongst women of reproductive age in our country. And if you consider that 30% of our antenatal group are HIV positive, that is a huge burden of disease when it comes to iron deficiency. So how can we assess heavy menstrual bleeding? If you look at this pictorial assessment chart, it's a nice thing to have in your practice, because if you print it out, you can give it to the patient. They can score what their menstrual period is like, whether they've got just the center of their pad or the whole pad or a little bit of their tampon, etc. And you can add up the score. And if you're getting a score of more than 100 points, this indicates heavy menstrual bleeding. So instead of it being subjective, you can make it much more objective if you've got a pictorial menstrual assessment chart. And this is what's used in a lot of trials. So now we go to terminology. All of us know the old term menorrhagia. And menorrhagia, in fact, is to burst forth each month. Isn't that fantastic, that description? To burst forth with excessive uterine bleeding. If you look at all of these definitions, polymenorrhea, hypermenorrhea, dysfunctional uterine bleeding, there was a lot of work done. And in fact, in a congress that was in Cape Town, they showed that because there was so much intervariation amongst practitioners, this terminology has been chucked out. So we no longer teach students or registrars the word menorrhagia, and we now use the word heavy menstrual bleeding. And we need to describe the heavy menstrual bleeding in various parameters. So how frequent, its amount, is it prolonged heavy menstrual bleeding? Is it normal menstrual bleeding? The regularity, whether it's intermenstrual bleeding or whether it's unscheduled bleeding. And that goes together with a system called the Palm-Cohen system. So FIGO's classification of heavy menstrual bleeding is you use the description, and then you use one of these PAL or M or the COEIN to describe heavy menstrual bleeding. So you can say heavy menstrual bleeding A, and that means that that patient, if you're writing an article or you're writing your assessment, that means a patient has heavy menstrual bleeding due to adenomyosis. Or if they've got heavy menstrual bleeding or HMBO, that is heavy menstrual bleeding, ovulatory dysfunction. So the palm of your hand are the pathological things, and the Cohen are the other things that are related to coagulopathies, ovulation dysfunction, endometrial pathologies, iatrogenic or not yet classified. So that's now how we describe heavy menstrual bleeding in the literature. If you look at it in this nice pictorial diagram, it also gives you a pictorial idea of how to describe it. And most of the cone is in young women, and the palms are often in older women when you talk about heavy bleeding. So here you've combined the two. You've said this person has heavy menstrual bleeding and whether they have a polyp or a coagulopathy. So I hope all of you, when you start reading literature, will now use this terminology. So what do we know about heavy menstrual blood loss in association with low concentrations of hemoglobin? Obviously, if you bleed more than 80 mils per cycle, you're much more likely to have a low hemoglobin. But if you look at this pictorial chart in this study, what they found that in the incidence of iron deficiency anemia, with anemia or without anemia, the vast majority is caused by heavy menstrual bleeding. And the other causes such as GI bleeding, nutritional, Crohn's, colitis, etc., are in fact much less common in the reproductive woman compared to heavy menstrual bleeding. So it is a significant cause of iron deficiency amongst women. So what does iron deficiency in women do? Well, iron is important for energy production. It's important for respiration. It's important for DNA synthesis and repair, cell division, and meiotic function. So menstrual health is really linked to many things. It's linked to your physical well-being, your mental well-being, your social, emotional, and obviously, like we discussed before, financial well-being. And these things are important to take into consideration for young women. We are a vital part of our society, and we deserve to have the very best care. And menstruation does not have to be a burden. What can iron deficiency do? Well, iron deficiency, if it's mild to moderate, causes the classical symptoms of fatigue, weakness, and shortness of breath. But we often forget about the other symptoms, particularly hair loss, headaches, brittle nails, cold insensitivity, restless leg syndrome, sleep. It's one of the biggest causes of sleep deprivation amongst particularly adolescents, and even in infants who have iron deficiency anemia have sleep problems, depression, and in fact, I'll show you even cognition. So iron's effect on the brain is far more than we thought before. In fact, not only just iron deficiency, but also iron overload. People who have iron overload actually have altered social behavior with cognitive decline. But people with iron deficiency also have problems with their cognitive development, functional development, and neurophysiology. And it's, in fact, if you look at psychiatric patients, psychiatric disorders or within patients with iron deficiency anemia are much more common than we thought. And it's associated with anxiety disorders, depression, sleep, and psychotic. So any patient who's been treated basically for a psychiatric disorder needs to have both an iron, vitamin D, and folate measurement. Iron status has also been shown to have an effect on cognition and academic performance. So anemia has been found to be associated with an attention and concentration performance. And in fact, you drop your IQ by 2.5 points when you have a deficiency in iron. Iron status and anemia influences school performance. And in fact, it's important when we consider this, but there's actually no evidence to suggest that iron status, anemia, and food-based interventions or iron supplementations will influence your memory and recall. So I don't want you to rush out and take iron tablets and think that you're going to be much more cleverer than you are. But certainly if you have an iron deficiency anemia, your IQ might be slightly lower than it should be. What about inflammation and endometrial bleeding? It's quite interesting that we know that this process of healing within the endometrium when you have a period, if you have a heavy period, can cause dysregulation and endometriosis development. So have a look at this really schematic diagram that's a bit intense. What you'll see is during menstruation, basically you have hypoxic stress with an increase in release with your VEGF. You get apoptosis, you increase shedding, you get a whole lot of cell-mediated release with cytokines. And that whole inflammatory process is very well balanced in women who have normal menstruation. But in women who have abnormal menstrual bleeding or heavy menstrual bleeding, it can result in retrograde menstruation and endometriosis formation. And in fact, heavy menstrual bleeding can occur in women who have endometriosis. The other interesting thing is I don't think people appreciate is that iron deficiency itself increases bleeding. So what happens is you have heavy menstrual blood loss, and what it does is generally you get a significant decrease in your prostaglandin F2 alpha to your prostaglandin E2 ratio. And what this does is it doesn't cause your spiral arterioles to constrict. So in fact, iron deficiency makes iron deficiency worse. So it becomes this vicious cycle like the chicken and hen. But if you fix the iron deficiency, often you can decrease the heavy menstrual bleeding. So it is really important for you to consider that when you are seeing young women. So which investigation should you do on Mrs. HMB's 16-year-old daughter? Should you do a full blood count? Should you do a ferritin? Should you do iron studies? Or should you do a ferritin with a full blood count? So there's been many reviews, but the latest one from 2021 really takes into consideration all the guidelines that occur. And so 3 of the guidelines said serum ferritin, 6 of the guidelines liked iron testing, and 4 of the guidelines felt that iron testing should not be routine. And in fact, we've adopted the policy that a ferritin, particularly in somebody who doesn't have an inflammatory process, is sufficient. And if you've got a low serum ferritin, less than 30, this would indicate diminished iron stores. Because remember, ferritin can be raised in inflammation. So you have to be careful in women who have an inflammatory process. They may still have iron deficiency anemia, even if their ferritin is up. But generally, ferritin less than 30 indicates iron deficiency. So in this nice schematic diagram, you'll see that you should diagnose the anemia, and routinely in women who present with heavy menstrual bleeding. And iron deficiency in the absence of anemia affects patients' quality of life. So you should be treating them with oral medication. Obviously, you must diagnose the underlying cause, treat the underlying cause, and monitor the patient and go back to measuring the ferritin. So there's 2 pillars to your management. The first is to address the iron deficiency anemia and the cause together, and not just address the cause and not treat the iron deficiency anemia. You have to do the 2 of them together. This is a schematic diagram that's very full and detailed, but just really to take a good history. And I think what I want to point out here is what is interesting is von Willebrand's disease. In fact, in a study, they showed that 10% of young girls with heavy menstrual bleeding have von Willebrand's. And you need to also take a family history. Did the mother have a postpartum hemorrhage? Did the mother have heavy menstrual bleeding herself? And if they did, then you need to think about a coagulopathy. We don't often consider testing patients, I think, because we don't take a good enough history in order to recognize a coagulopathy within family lines. But certainly remember, when you are going to test for von Willebrand's, you need to do 3 tests in order to show that von Willebrand's is present. So Mrs. HMB daughter has a ferritin of 16. You addressed the bleeding by putting her on an oral contraceptive because you felt that it was due to ovulatory problems. So how else would you treat her? Will you let her increase her red meat intake? Will you give her oral iron on alternate days with vitamin C? Or will you give her intravenous iron? So what the guidelines say is that you should use oral iron, that it is preferred initially, and particularly in young girls who have non-severe anemia, who are functional, and in patients with a confirmed iron deficiency anemia or just iron deficiency on its own, without anemia, you must give iron. And you can use it to correct the anemia in patients who there's a long interval before they require surgery. In fact, now in Gynaecology, all our patients should be having iron studies prior to surgery because, in fact, iron deficiency increases bleeding at surgery. So we always make sure that the patient's iron is adequate before we operate on them. So in non-anemic patients with confirmed iron deficiency, certainly oral, and then obviously in patients who are at high risk of developing an iron deficiency and those with a poor diet in iron-rich foods. And you would consider intravenous iron in patients who are severely anemic, who are pre-surgery and you're going to go to surgery early, or those who are not compliant or are non-responders. So what are our treatment options? So oral iron should be taken in divided doses of 100 to 200 milligrams per day of elemental iron. And oral iron is commonly administered in the form of ferrous salts, but there are many other kinds of iron. But what we know is that people who take iron long-term have hampered gastrointestinal effects. So initially they're okay, but then they start developing constipation, nausea, and vomiting. And so your choice of iron can change. There are numerous formulations available. All are probably equally as effective, but some are more effective for some women than others. And absorption and tolerance are the things that you need to think about. What we do now know is that if you give iron on alternate days, often it's more tolerated and absorption is better than if you give it daily. And if you give it in divided doses, it probably is better for patients. What is interesting, though, is that there's actually no high-quality data to suggest that giving vitamin C with iron actually improves absorption. I know we are all taught that, and there is anecdotal data. There certainly is probably some epidemiological, but there is no randomized, placebo-controlled, good quality data to say that it actually does work. The one thing that we do know, however, is that many foods interact with dietary iron, such as tannins and phosphates, and that these decrease the binding of iron and impair absorption. And so iron generally should not be given with food. And you should take your iron 2 hours before or 4 hours after having an antacid. And you can't believe how many patients take antacids, probably unprescribed, the majority of them, so always ask the question. So how do you improve tolerability? So first, you can increase the interval to every other day. You can make dietary modifications, even though you know it's not going to be absorbed so well. So if the patient's not tolerating it, you can ask them to have it with a little bit of food. You can switch the formulation to a lower amount of elemental iron or to a micromolecular iron, or you could switch from the table to the liquid form. But once a tolerated dose is found, the patient can sometimes increase the dose slowly so that they improve the amount of iron they actually take. So when do you switch to intravenous iron? Obviously, in patients with poor adherence or gastrointestinal side effects to oral iron, we prefer to replete iron stores in 1 or 2 visits rather than in a one-hit wonder. And ongoing blood loss, obviously, you know, if you fill the tank here and it's emptying out the bottom at a more rapid rate, then you probably need to give intravenous iron. You're not going to manage to keep up with oral iron. The other thing is that if there are anatomical or physiological conditions that interfere with iron absorption, you would give it intravenously. And then coexisting inflammatory states that affect iron homeostasis are really important to take into consideration. So there are many advantages and disadvantages to both. Obviously, the advantage for the patients to take oral iron is that there are extremely low risk of serious adverse events and that the cost is much lower compared to intravenous iron. Obviously, with intravenous iron, compliance is assured and you don't get gastrointestinal side effects, and you can give a bigger rapid dose. And you also get rapid resolution of your anemia. So for instance, in our pre-op patients, where we're going to operate in 2 or 3 weeks, then we would prefer to use intravenous iron. The disadvantages, we know, the gastrointestinal in the oral, but really the disadvantages of the intravenous is that patients require monitoring. You can, and I have certainly had a patient with an anaphylaxis from intravenous iron, and it requires obviously personnel and equipment, and particularly in cost constraints environments, it is a problem for us. So I think our key issues in heavy menstrual bleeding is that there's insufficient awareness of the serious long-term clinical consequences of the condition, and it's undertreated and underdiagnosed. And iron deficiency or iron deficiency anemia, so remember, you don't have to be anemic, you can just be iron deficient, increases morbidity negatively and impacts on quality of life of young women. And serum ferritin is probably the most reliable indicator of iron deficiency when inflammation or chronic disease is not present. And oral iron should be the first line of treatment for our iron deficiency, and only in cases of inadequate response or intolerance would you consider IV iron. So I really hope that what I've said to you is I want you to be aware of heavy menstrual bleeding. We can discuss in questions on how to manage it, but really this is about being aware of the situation, being so acutely aware of it. So many of us don't take an adequate menstrual history, and I would urge you all to do that so that we can improve women's sleep, their mental capacity, their emotional, physical, and their financial capacity. Thank you. Any questions?
So we do not have any questions in the question and answer or in the chats. If there's anybody that's got any questions, please remember to post your questions in the chat boxes so we can answer those questions. It's not every day that we have access to all the speakers and they can answer all the difficult things that everybody is battling with every day.
So the question is on that scoring chart, does the patient need to count each tampon? Yes, they do. So if you have a look, I think we are going to, Adele, send you a summary, and you'll see that that chart is there. And yes, they need to count the number of pads and the number of tampons, and each one has a score next to it. You'll see there whether it's soaked, it gets, I can't remember, 5 or 10 points. And if it's not so soaked, it gets less points. So each day they will need to mark or note how many they use. And just to say, in terms of the management, obviously iron is very important, but you need to go back to your Figo palm coin and decide what the cause of the heavy menstrual bleeding is. So in young adolescents, like we said, it can be a coagulopathy, but I had a question from our transplant team. There was a patient with very heavy menstrual bleeding, and the patient was 18 years of age. She required a liver transplant and had liver dysfunction. And the question is whether you can use a levonorgestrel containing intrauterine device in a young girl. And in fact, you can. And we often use a levonorgestrel IUD I've used it even in a 14-year-old with heavy menstrual bleeding to get control of the bleeding, because she was unable to take a combined oral contraceptive. So I think that the days of shining away from IUDs, the levonorgestrel containing IUDs, I mean, you get a low dose one that is smaller than the high dose one, but a high dose levonorgestrel IUD, in fact, controls heavy menstrual bleeding very well in these young girls. So you've got a two-prong approach. You must replace the iron, otherwise they're going to continue bleeding, and you must address the cause.
Then we've got a couple of other questions as well. Dr. Trudie, what is your opinion on the endosomal ions and the side effect profile? I'm not sure whether
So the
you have
endosomal ions, I mean, they seem to have far less side effect profile than the other ferrous compounds, as far as I know. I think that, if you're having trouble with one, then you would switch to the other. But I know the GIT side effects seem to be much less, if I'm not mistaken, on the endosomal ions. You probably could answer that better.
Okay, then we're going on to the next question is, how long should we give oral iron to work before giving IV iron?
So generally, I don't think there's an exact timeline on that, but I would normally see my patients within 6 weeks to check their ferritin level and ask them about their tolerance of oral iron, because you don't want to bash on and leave them. They're going to stop their medication if they're getting side effects from it, and they're not going to replace it. And that is going to be an opportunity lost. So I certainly wouldn't go like 6 months at all. But, if they're not responding to the oral iron, why aren't they? You could switch to, for instance, an endosomal iron, or you could switch to a liquid form of iron and see if they don't tolerate it. But obviously, if they're severely symptomatic, then you need to consider intravenous iron.
Then our next question is, how does Primalit help with HMB?
So Primalut is a progestogen. So usually Primalut is used in women who are having ovulatory dysfunction. So in young women, or in other women who are having an ovulatory cycle with heavy menstrual bleeding, you can use Primalut in the second half of the cycle. The problem often with Primalut is patients have to count the days. So they use it for 14 days in the second half of the cycle. You can use it throughout a cycle for 25 days, but the efficacy seems to be less. And then always important to tell the patients that if you're giving them Primulute for 10 days, when they stop the Primulute 2 days later or so, they will have another bleed. So that's why you need to cycle your Primulute. So then I tell my patients, day 1 of the bleed is day 1. You count 14 days, then you start the Primulute for 14 days, and 2 days later, you'll have a bleed. So essentially, they should be having then cycles of 30 days. So it's a good alternative for somebody who doesn't want to go onto an oral contraceptive or can't go onto a combined oral contraceptive. Because remember that if there's a clotting problem, you can't use an estradiol or ethinyl estradiol combined oral contraceptive. And, you know, those are progestogens. So there are various progestogens you can use. You can use medroxyprogesterone acetate. So we're not using trade names here, but medroxyprogesterone acetate, you can use 10 milligrams twice a day in the second half of the cycle.
Then our next question is an anonymous question. And how long after iron treatment do we check ferritin levels?
So you check ferritin levels during your iron treatment, and then obviously you have to assess that you fix the heavy menstrual bleeding. So it's no good stopping your once your ferritin's up, but you haven't fixed the initial problem, it's just going to drop again. So you have to do the two together. So once the iron, ferritin levels are up and you've addressed the heavy menstrual bleeding at the same time, then obviously you can discontinue the iron. But, it's no good getting the ferritin up, but you're still pouring on the other side because it's just going to drop again.
Then our next question is, so does the 16-year-old girl with HMB have to go and see a doctor, or can she just start taking supplements?
She can take supplements, but who's managing her heavy menstrual bleeding? So the supplements might improve her bleeding a little bit, but somebody needs to still address her heavy menstrual bleeding. And she could be having heavy menstrual bleeding because she's having anovulatory cycles. So she does need to have that addressed.
Our next question, is it worthwhile doing full iron studies as a baseline, or only HB and ferritin as a baseline in heavy menstrual bleeding?
I think from a cost perspective, an HB with a ferritin is sufficient. I mean, you could do just a full blood count, and that'll tell you if you've got a microcytic hypochromic anemia as well, but it's not accurate. If you really want to look at something accurately, you could do just a ferritin level. But obviously, if somebody's severely symptomatic, you might want to know what their hemoglobin is.
So the next question we have is just for clarification, is can I kindly check so vitamin C does not increase absorption of iron?
So what we're saying is vitamin C is said to increase the absorption of iron, probably does increase the absorption of iron, but interestingly enough, we don't have hard data on it. So yes, you can use the two together. And I often tell patients, have a glass of orange juice with your iron tablets. That can also do the trick.
If I can maybe just add there, it helps with the conversion of Fe3 to Fe2. So it helps to increase your dietary iron. And if you are taking an Fe3 iron, then it helps to with that conversion. Maybe that can just add to that question as well.
Absolutely. So yes, I would use it for sure. I see there's a question. Can you comment on the use of Dynagest in a patient age 23 presenting with heavy menstrual bleeding and endometriosis? So Dynagest is a progestogen, a potent progestogen that has a good efficacy in endometriosis and should be first line. And yes, all patients who are treated or even in patients you suspect have endometriosis, it's your first line of management. To put a patient on Dynagest, the progestogen. It has better efficacy than the other progestogens from an endometriosis perspective. And so this 23-year-old patient should remain on Dynagest until conception is required.
Then the next question is to do with tranexamic acid, if I'm pronouncing it in the correct way.
Yes.
Is the long-term clinical use of tranexamic acid a good option?
So tranexamic acid in heavy menstrual bleeding works very well at correct dosing. So the correct dosing of tranexamic acid is 1 gram QID in patients with heavy menstrual bleeding, but certainly not less than 3 times a day. And it should be used for a maximum of 4 days. So we use it in the 4 heaviest bleeding days of patients. So in patients who do not wish to take any form of hormonal treatment and want to just try and control their heavy menstrual bleeding, we would use tranexamic acid for the first 4 heavy bleeding days.
So the next one, I'll just read the intro. So all iron supplements are definitely not equal. The older generation ferric ones cause gastric symptoms, which can be incredibly painful and uncomfortable. I don't think we should even be trialing these older formulations to see how well someone tolerates it when we have newer formulations like sucrosomal iron with ample good quality data supporting its use. I also wanted to comment on how IV iron is often indicated even before oral ease. For many people, the symptoms of iron deficiency is so debilitating that the quickest treatment is the most appropriate one. And I would appreciate the comments.
Yeah, I absolutely agree. But unfortunately, many patients don't have access to funding for the new iron supplementation. And some of the non-private sector patients only have access to the older iron formularies. And I absolutely agree that intravenous iron must be used in those patients with severe iron deficiency anemia with symptoms, because there's no doubt that you don't have, it takes a long time from an oral iron perspective. So if you have a severe iron deficiency anemia, I definitely would give intravenous iron.
In the next question, in young patients, for example, 15-year-olds, which is a preferred oral contraceptive?
Okay, interesting question. So the new estradiol containing contraceptives have been trialed and a head-to-head trial with the levonorgestrel intrauterine device. And in fact, if you look at the data on the new estradiol containing oral contraceptives, there's one that is monophasic, and there's one that is tri or quadriphasic, actually. Those are the only 2 on the market. They have good data on heavy menstrual bleeding, which is equivocal to a levonorgestrel containing intrauterine device. So I would probably start an adolescent on one of those, but remembering that it is a more expensive form of combined oral contraceptive compared to the old ethinyl estradiol oral contraceptives, which may be a lot cheaper. The other thing to take into consideration in a young girl is whether they have other problems. So for instance, if they have acne, hirsutism, and skin side effects, then you would rather use a combined oral contraceptive that contains anti-androgenic properties in its progestogen. So it's about taking the patient as an individual and their other symptoms and their compliance. So the average adolescent, in fact, will miss 2.4 pills per month. Compliance is a problem. And when compliance is a problem, they'll have intermenstrual bleeding, and they won't get their bleeding under control. And then in those cases, you might need to use a levonorgestrel intrauterine device.
Then thank you for your presentation, says Karen. Please could you explain why alternate day iron supplementation works better than daily dosing? So I think Prof. Lowe also addressed this in one of the previous talks, but you're welcome to give your opinion as well, and then maybe I can also make a comment.
Yeah, if I'm not mistaken, there was a trial where they looked at daily dosing compared to alternate day dosing, and they found absorption and GIT side effects were less. Am I not correct?
Yeah, so the trial that was done on ferrous sulfates. So what you find with the ferrous sulfates, which is highly likely to cause quite a lot of side effects, is that you find the soluble iron salts, the absorption or the bioavailability is generally high, but the absorption is almost just around about 10%. But because of the high bioavailability, it increases the hepcidin levels. And then because the hepcidin levels goes up, then your iron absorption stops or it lowers. And then if a patient is using the ferrous sulfate every second or every alternate day, then it gives a chance for the hepcidin to go back to normal again. But you would find with the new agents that's available on the sucrosomal side and the endosomal ions, those are hepcidin independent. So those ones you can use every day, and you don't need to use those every second day. So it's mainly on the ferrous sulfates. That's where the study was done.
Yeah,
Because
that
is not hepcidin
because
independent.
of the absorption. Absolutely, I agree with you.
Okay, then if they can't use or afford hormonal IUCDs, I'm not sure what that is, maybe it's just a spelling error, what would you suggest next?
So progestogen-only contraceptives such as the injectables, the 3-monthly injectables and the 2-monthly injectables will also decrease bleeding, and it, in the vast majority of young girls, will cause amenorrhea. Our only problem with the injectable contraceptives, which are cheap and freely available, particularly within the government sector, is if you use it in adolescence, you don't get good bone health. So the injectables are associated with poor bone health. So we try not to use it in young adolescents and in perimenopausal women. But if cost is a problem, then that would be a solution.
Our next question is, what's the role of folic acid and iron FDC in iron deficiency, or iron sulfate is fine alone?
Well, I mean, you know, iron deficiency anemia is separate to folic acid anemia. And I'm not sure, Dal, you'd have to correct me, that folic acid has not been shown to assist in iron absorption. If I'm not mistaken.
It's more contributing, and Shai, you would most probably also be able to help with this question.
Yes, so we know that when it comes to your megaloblastic anemics, that your B12 and folate can be deficiencies that we can screen for in the process of erythropoiesis. And that's where your folic acid would contribute if your patient was folic acid deficient. And then we also know that some of our oral contraceptives, unfortunately, are not fortified with folic acid, and that could play a role there as well.
So I mean, that you would on your full blood count have a macrocytic hypochromic anemia as opposed to a microcytic anemia. So that's where your folic acid. But, you know, if you're thinking about a pregnant woman, the folic acid is not for anemia. The folic acid is for neural tube development in women in the first trimester. That's why folic acid is given.
So then we also have, it's most probably the last question that we have is, patient in late 20s presents with heavy menstrual bleeding and migraines that appear cyclical on ovulation, are oral contraceptives appropriate?
So you can get two types. In fact, you get three types of migraines. You get migraines with aura, migraines without aura, you get menstrual migraines, and you get ovulatory migraines. The first thing is to find out if there's an aura or no aura. If there is an aura with migraines, all combined oral contraceptives are a relative contraindication, and I would not use them. In patients with menstrual migraines, and that needs to be documented with a diary, I use either the estradiol-containing oral contraceptive that only has 2 placebos, or I will use a combined oral contraceptive without placebos. Remember, the oral contraceptive pill was designed by men for women who thought we wanted periods. There's no reason to take those placebos whatsoever. If you don't take a single placebo and you don't have breakthrough bleeding, it doesn't matter, and it doesn't impact on fertility or any of those problems. So in somebody with an aura, I certainly, even if they think it is at the time of ovulation, I would not use a combined oral contraceptive, but you can use a progestogen-only contraceptive, and that would inhibit ovulation, particularly with one of the newer high-dose progesterone-only contraceptives. But in somebody without an aura, you can use a combined oral contraceptive.
Okay, so we managed to go through all the questions, and I think that would be closing our Q&A session. So Dr. Trudie, thank you so much for an informative presentation on understanding the impact of heavy menstrual bleeding on iron stores. And I really think what the point that you've highlighted as well is to make everyone aware of it, so that they know how to treat it when they come across it, and how to look for it as well. So as we mentioned earlier, you will have access to the recording, a supportive downloadable workbook, and 10 multiple choice questions, of which the workbook and the questionnaire are already available via the same link you used to register for tonight's event, or the link in the chat box. You will soon receive a follow-up email reiterating the step-by-step guide on how to access all the recorded content, including the downloadable PDF modules and CPD questionnaires of all the talks that took place so far, including tonight's, in case you missed any of the prior events. And that, on behalf of INOVA, thank you again, Dr. Trudie, and to all our guests for attending tonight. We look forward to the next event on Iron Symphony and Forging Minds, Harmonizing Maternal Wellness and Fetal Intelligence, which will take place on the 20th of August, presented by Professor Vernon Lowe again. And then have a wonderful evening and stay warm. Thank you so much for your attendance.
Good night.
Good night.